Hello, this is Dr. Sakhnini speaking. Assalamu alaikum. Presenting for you a case of a young lady, 20 years old, who presented with us 1 year after laceration of the right digital nerve of her index. She was treated with nerve suture somewhere else, as the reports say, but clinically she had a positive TNL over the scar and non-functional index with no active full range of motion. Passively, we could make a fist, the joints were supple. She was offered surgery to treat the suspected neuroma. The main idea was to reconstruct this critical sensation with an autograft. So we did a mid-axial approach. My experience is that this approach is very good to explore the digital nerve and even reconstruct it if needed. Here we see a proximal part of the digital nerve. There is a branching. There's two parts of the digital nerve. One goes for the cutaneous part. Anyhow, we find the proximal part, we find the distal part, and in the middle there's scarring that is stuck to the cutaneous part of the finger. And then the idea is to raise both limbs on a visual loop and then dig out the neuroma, take it out, and think about reconstruction. We have to make a decision how to reconstruct this critical sensation. We know that it's a neuroma in continuity, as the both limbs of the nerves are connected, but there is a scar in the middle that is stuck to the cutaneous part. So this is one branch of the proper digital nerve, and we put it in a visual loop, proximally, distally, followed by dissection. So there are two purposes of this surgery. One is to treat pain. Two is to reconstruct a critical sensation needed for pinch, the radial part of the index. So it is not really some kind of non-critical sensation that we could sacrifice without a problem. That, for example, can be treated in a TMR, centrocentral, bearing, or capping, or even neurectomy. Here we have to deal with two purposes. The idea or the plan was to reconstruct it with a autograft. Other options would be a allograft or a wrapping with a over-the-counter protector or even a vein graft, a vein conduit. We here took out this scar. Inside there is a bulb-like neuroma. We dissect it here to see if even there is a nerve tissue, but we see that it's all scar and there is no fascicles as we look with the loops. Now we have to decide how to continue. We trim both parts of the digital nerve, but as we check here, two limbs of the nerve could get to each other without tension, with a full range of motion. This was surprising after 1 year of injury, but we did a good neurolysis, and this gave us the option to do a primary suturing for the digital nerve without tension to get the sensation back. And after we got rid of the neuroma, we will protect this suturing with a protector, with a sleeve in order to obviate rescarring. We will also start a immediate range of motion to make the nerve glide without tension, without hyperextension. We'll make extension block to obviate unneeded tension over the suturing. We suture with 10-0 nylon both parts of this branching of the digital nerve, the common digital, of the proper radial digital. And if we think about what options we have other than reconstruction, primarily or autograft, allograft, or protector or conduit, we could also do a nerve transfer from a non-critical digital nerve. But then we have to deal with the proximal stump, which could be a source of problem. And then we can transfer it even in a TMR-like fashion. This would be another option. So as we can hear, there is versatile techniques and options to deal with this problem, as we have to achieve in this specific case a double goals. One, to take out the pain, which I think is more important than reconstructing the critical sensation, because pain in this area, in this specific case, hindered function of the hand. She could not do a good pen. She did not flex her index because of tension over the scar. So we have sometimes, if we want to make a trade between pain and reconstruction of sensation, I think that we have to make a priority than taking out of pain to deal with the neuroma. So this is, I think, is important. Then we think about the reconstruction. So after we did the suturing, now we want to wrap it with a protector in order to make a no scar zone, and obviate this problem, and to hinder the axonal escape that could endanger us and get us back to the first square of positive TNL and neuroma symptoms. Thank you for seeing this video. I hope you enjoyed it, and salamu alaikum.